Hospice billing operates under one of the most rigorously scrutinized regulatory microscopes in American healthcare. A single missed physician certification or untimely notice of election turns a fully covered claim into a complete denial. The Centers for Medicare and Medicaid Services tracks exactly how often these failures happen. According to their 2024 data, the improper payment rate for non-hospital-based hospice services sits at exactly 6.8%. This chart translates that percentage into the raw financial stakes for the industry. That 6.8% represents approximately $1.6 billion in projected improper payments for a single reporting cycle. CMS data breaks down exactly where those errors come from, and it reveals a clear execution gap. The government knows this massive leakage is almost never intentional fraud. Look at the distribution. 63% of these improper payments stem entirely from insufficient documentation. Another 15.9% occur because there is no documentation submitted at all. Medical necessity failures account for 17.4%, while incorrect coding contributes a mere 1.1%. The revenue leak is a documentation execution problem, not a clinical intent problem. Hospice agencies bleed revenue because they fail to capture and submit the precise evidentiary sequence required by Medicare. To understand why that evidentiary sequence breaks down, you have to look at the structure of the Medicare benefit itself. It pays at 4 distinct levels of care. This diagram maps those 4 tiers: routine home care, continuous home care, general inpatient care, and inpatient respite care. Each carries unique documentation rules and specific audit exposure. Most billing teams process routine home care effortlessly. The financial and compliance dangers cluster sharply in the remaining 3 tiers. General inpatient care, or GIP, requires the highest level of scrutiny. It is the most expensive level of hospice care and the most frequently audited. In a landmark audit, the Office of Inspector General found that hospices inappropriately billed approximately 1/3 of all GIP stays, often using it when only routine care was necessary. A GIP claim is instantly flagged when an interdisciplinary team fails to document that a patient's symptoms absolutely could not be managed at home. If that specific judgment is missing, the claim becomes a target. Continuous home care demands a different kind of precision. Visit start and stop times must be recorded for every single interaction. Missing a start time on one nursing visit will invalidate hours of legitimate care. Minor administrative oversights in these upper tiers trigger total claim recoupments and invite systemic audits from Medicare contractors. Securing payment requires a rigid chronological sequence. Missing one early documentation deadline poisons the entire benefit period. This timeline tracks a standard admission. The sequence begins with hard deadlines: filing a timely notice of election and securing the physician certification. Subsequent hurdles follow. Face-to-face encounters must occur before the 3rd benefit period. Failing any single checkpoint turns the remaining timeline red. CMS contractors do not view these missed deadlines as clerical errors. They respond with aggressive, zero-tolerance oversight. In 2023, CMS implemented the Provisional Period of Enhanced Oversight Program, subjecting specific hospices to intense medical review. By 2025, they expanded the program into multiple new states. Data tracking the impact of these PPEO reviews shows that billing privileges were revoked for 122 hospices, with that subset of providers facing a 40% denial rate for claims. This local pressure matches a heavy national trend. Kodiak Solutions reported that net revenue leakage across the healthcare sector grew 25% in a single year, surging past $48 billion. Relying on a stretched team of billing generalists to navigate an audit environment this aggressive is an operational gamble. When hospice administrators discuss these revenue failures, they typically point to staffing shortages before they examine their billing protocols.
The true engine of the execution gap is high turnover. Essential institutional knowledge constantly walks out the door. The Medical Group Management Association tracked this exact problem, finding that business operations and billing support staff experienced a massive 33.3% turnover rate in a single year. This flowchart visualizes the compounding cost of that turnover. When a highly trained specialist leaves, they take their specific knowledge of your payer mix and GIP coding quirks with them. The replacement worker requires months of rigorous training. During that ramp-up phase, as the new employee tries to learn the system, documentation errors and missed NOEs quietly accumulate in the live queue. Add clinical strain to the equation. Texas workforce data shows hospice LVN vacancy rates sitting at 22.2%. To cover the gaps, internal billing teams are frequently pulled away to handle intake paperwork and answer phones. You simply cannot secure a highly technical, strictly regulated revenue system using a rotating door of distracted employees. High-performing hospice agencies stabilize their revenue cycles by completely decoupling billing execution from internal HR constraints. They achieve this through specialized integration, using companies like Staffingly to embed outsourced billing teams as a dedicated extension of their in-house staff. The talent profile is highly specific. These are exclusively AAPC and AIHMA credentialed specialists who only handle hospice billing. They are not general medical billers. The integration mechanics require no new software. Whether an agency runs Epic, Athena, Cerner, or eClinicalWorks, the specialists log in and work directly inside the agency's existing EMR every single day. Agencies are assigned a specific, dedicated person. There are no shared pools and no rotating contractors. Staffingly connects to the EMR within 48 hours, and teams go live in just 14 days, entirely bypassing long-term contract lock-ins. This operational shift ensures that institutional knowledge is preserved in the system, solving the 33 automated pre-submission audits, cross-reference every claim against CMS documentation checklists, catching missed NOE timelines or face-to-face encounter gaps before the file ever leaves the system. This combination of human expertise and automated auditing produces a direct result. Agencies using this model maintain claim error rates below 1%. Reducing an error rate from the 6.8% national average to under 1% physically shields an agency from PPEO audit exposure. For CFOs and agency owners, the final determining factor is the raw cost comparison between these two models. An in-house billing FTE averages up to $75,000 per year when factoring in salary, benefits, and training. The Staffingly model eliminates the benefits and turnover hit entirely, delivering the exact same daily work for roughly $20,700 per year. The reliability of this system is validated across more than 800 medical practices nationwide, collectively saving healthcare clients over $14 million. A 14-day risk-free pilot allows agencies to verify the output in their own EMR, with the flexibility to scale up or down with 30 days' notice.